friends, this is Nishanat Gautam, Associate Professor from the Department of Pharmacology, Laureate Institute of Pharmacy. Today we will discuss about the chapter Diuretics belongs to your second unit, drug acting on the cardiovascular system. This is a very big chapter, so I have divided this chapter into the 4 parts for your convenience. One by one, each and every part we will discuss and continue the description about the diuretics. So let us start with some of the introductory description of the diuretics. The diuretics are those agents or the drugs which causes a net loss of the sodium with that of the water in the urine. The diuretics are also called as the natriuretics. However, the sodium balance is soon restored even with the continuing diuretic action by the compensatory homeostatic mechanisms of the body. Allied with a certain degree of persisting sodium deficit and reduction in extracellular fluid volume. Further, they are used to reduce the abnormal accumulation of excess fluid in the body. The diuretics act to modulate different processes to reduce sodium and water reabsorption, resulting in increased water excretion. The diuretics are chemicals that increases the rate of urine formation by increasing the urine flow rate in the kidney, and diuretic uses leads to the increased excretion of electrolytes, mainly as already we discussed, those are the sodium and the chloride ion and water from the body along with the potassium. Then the diuretics reduces the excess accumulation of the fluid in the body. So also diuretics are among the most widely prescribed drugs, and its application is mainly in the management of hypertension to reduce the blood volume. But the question arises, a different kind of the diuretics are we using, and all the diuretics showing the increase in the urine formation. So question arises, how can all the diuretics shows the same action, that is the diuresis, means the net loss of the sodium with that of the water. To get the answer of this question, first we have to go through the normal physiology of the urine formation. In short, we have to know the physiology of the urine formation. Before to start the normal physiological description of the urine formation, we have to know about the parts of the kidney. The kidney is composed of cortex, medullary pyramid, renal sinus, renal artery, renal pelvis, renal vein, major calyx, minor calyx, and ureter. These are the major components of the kidney. Here it is clearly mentioned in this diagram. And the basic structural and functional unit of the kidney is the nephron, which is composed of afferent and efferent arteriole, glomerulus, boundless capsule, proximal convoluted tubule, thick descending segment, thin descending segment, loop of the Henleys, that is the thin ascending segment and the thick ascending segment, and the distal convoluted tubule, finally the collecting duct. So we will discuss one by one the normal physiology of the urine formation. Then we will go through the mechanism of the different type of the diuretics. Then only we can get the answer how can all the diuretic shows the same action. Now, before to start diuretics, let us go through the sneak peek into the nephron. Let us discuss about the secret functioning of the nephron. The nephron is the basic structural and functional unit of the kidney. So we will discuss in detail about that. It is clearly mentioned in this diagram and we can easily understand the mechanism and the physiological role of the nephron in the formation of the urine. So focus the first point. One by one we will discuss the functioning of the nephron. The first point is the renal capsule. From here we will start the description of nephron. Renal capsule is a spherical structure consisting of the glomerular capsule, a cup-shaped chamber, approximately 200 micrometer in diameter, and a capillary network known as the glomerulus. The second one after this is the proximal convoluted tubule. The proximal convoluted tubule is responsible for the reabsorbing nutrients from the filtrate, now known as tubular fluid. Then the third one is the nephron loop. The nephron loop is primarily responsible for the establishment of an osmotic gradient in the renal medulla. This gradient promotes water reabsorption from tubular fluid in the nephron and collecting system. It is of the two types, thin limb and the thick limb. Then the fourth one is the distal convoluted tubule. The distal convoluted tubule makes further adjustment in the composition of the tubular fluid through a combination of secretion and reabsorption. So the balance of secretion and reabsorption takes place at the DCT, distal convoluted tubule. Then after this structure of the nephron, which is get attached with that of the collecting system. So the collecting system receives the urine from individual nephron and perform final adjustment in urine volume and composition before delivering it to a minor calyx. First, go through the collecting duct. A collecting duct carries tubular fluid through a osmotic gradient in the renal medulla. Then the papillary duct. A papillary duct collects tubular fluid from multiple collecting ducts and deliver it to a minor calyx. This is how the urine formation is taking place through the physiological function of the nephron by the glomerular filtration, tubular reabsorption and the tubular secretion. Here the filtrate, water reabsorption, variable water reabsorption, solid reabsorption or secretion and variable solid reabsorption or the secretion is taking place throughout the physiology of the urine formation. This is how the nephron shows its physiology. So, for the revision purpose, I summarized the parts and the physiological role of the nephron through this animated diagram. The functional unit of kidney is nephron, and this nephron is composed of the following parts. This part is called as the glomerulus, as we made the discussion in the previous slide. Then afterwards, this portion is called as the proximal tubule. Then afterwards, this portion is called as the loop of Henry's. It is of the two types, thick loop of Henry's and the thin loop of the Henry's. Then afterwards, this portion is called as the distal tubule. And last, this one is called as the collecting duct. So these are the main 5 parts of the nephron, which is a basic functional unit of the kidney. Then the nephron shows the process of urine formation in the 3 steps. The process of urine formation by the nephron taking place by the 3 processes are: first is the ultrafiltration, also called as the glomerular filtration. Then the second one is called as the tubular reabsorption. After the tubular reabsorption, the process of tubular secretion is there. So, by these 3 physiological processes, the urine formation taking place. Then, let us summarize the renal physiology with respect to the pharmacological aspects. Pharmacologically, nephron is divided into the following 4 segments. The 4 sites of the nephron is pharmacologically divided to understand the mechanism of action of the process of diuresis. This portion is called as the site 1, that is the proximal convoluted tubule, as we discussed earlier, but pharmacologically or with the pharmacological aspect, it is considered as the site 1 of the nephron. This one is considered as a site 2, which is a thick ascending limb of loop of Henry's. And this one is considered as a site 3, that is the cortical diluting segment of loop of Henry's. And this one is considered as the site 4, that is composed of distal convoluted tubule and the collecting duct. Then, as already we discussed, the urine formation starts from the glomerular filtration in a prodigal way. Normally, about 180 liters of fluid is filtered every day. All soluble constituents of blood minus the plasma proteins along with substances bound to them and lipids are filtered at glomerulus. More than 90% of the glomerular filtrate is reabsorbed in the tubules. About 1.5 liter urine is produced in 24 hours. Actually, the mechanism that carry out ion movement across tubular cells are complex and involve a variety of energy-dependent transmembrane pumps, as well as the channels in between the loose-fitting cells of the proximal tubule. All sodium that enters the tubular cells through the luminal membrane is pumped out of it into a renal interstitium. at the basolateral membrane by the sodium potassium ATPase energize the sodium potassium antibody. Because there is a large intracellular to extracellular gradient for potassium, it diffuses out the potassium through the potassium channel to be recirculated by the sodium potassium antibody. For simplification, tubular reabsorption can be divided into the four sites that we already discussed earlier. Here again, we will discuss in detail about each and every site pharmacology. The site 1. See in this diagram, it is clearly seen the site 1. What happens in the site 1, I summarize over here. The movement of the sodium is taking place by the four mechanisms. First, the direct entry of the sodium. Coupled to active, the reabsorption of organic anide via specific synthetase. Then, the exchange of the sodium with the hydrogen ions by the sodium hydrogen antibody. Then the diffusion through the paracellular pathways. This is how by the four mechanisms the transportation of the sodium is taking place at the site 1. This one is the site 2. At the site 2, it is at the medullary portion of the kidney. The portion of the nephron located at the medullary portion carries the transport in the stoichiometric ratio of the sodium, potassium and 2 chlorides. This is an non-electrogenic. Here in this, the sodium potassium ATPase present at the basolateral membrane, which provides the movement of the sodium and potassium. Also with this, there is a sodium chloride synthetase is there. So both of these, sodium potassium ATPase and sodium chloride synthetase works to carry the transports of the ions in a stoichiometric ratio of the sodium, potassium and 2 chloride ratio. This is how the two sides shows the movements of the different ions through the active and the passive diffusion processes. Then, after the discussion of the site 1 proximal tubule and the site 2 ascending limb of loop of Andes, let us discuss about the site 3 and site 4. This one is the site 3. Before discussing about the site 3, let us go through the previous site, site 1. From the site 1, the isotonic urine enters into the loop of Andes. This isotonic urine becomes the hypertonic here in this segment. In this loop of Andes, there is the reabsorption of the water takes place, due to which this passive diffusion and the reabsorption of the water, the urine become hypertonic. This hypertonic urine moves towards the side 2, towards the thick ascending loop of the Andes. Here in this site also, there is the movement of the salt or the reabsorption of the salt takes place through a stoichiometric ratio of sodium, potassium and 2 chloride with the help of the sodium potassium ATPase and the sodium chloride synthetase. Whereas the chloride moves down to its electrochemical gradient into the extracellular fluid and carries the sodium along with it. So the urine again become hypotonic and it moves towards the side 3. And at the side 3, what happens? The segment is also called as cortical diluting segment of loop of Henry's. At this side or the segment, it is also impermeable to water and continues to absorb the salt. But here it is through the sodium chloride symporter. So the tubular fluid get further diluted here. Then the next side is the side 4. This side is called as the distal tubule and collecting duct. In the late distal tubule and collecting duct, the sodium is again actively reabsorbed, the cation-anion balance being maintained partially by passive chloride diffusion and partially by the secretion of potassium and the hydrogen. Absorption of sodium at this site occurs through a specific amiloride sensitive sodium channel and is controlled to a large extent by aldosterone. This provides a fine tuning to electrolyte excretion according to body needs. In common with other cells, the distal tubule and collecting duct cells are rich in the potassium. A chemical gradient exists for its diffusion into tubular lumen, which is aided by the lumen negative transepithelial potential difference. In this part of the nephron, the luminal membrane possesses an active secretory pump for the hydrogen, which is again governed by the movement of the sodium in the reverse direction. The variety of the secretory processes here depends on the sodium load delivery to the distal segment, presence or the absence of aldosterone, availability of hydrogen ion, intercellular potassium store. So here in this segment, the antidiuretic hormone also works to control the reabsorption or the passive diffusion of the water to control the diuresis process. The most important site of the nephron is the site 4. The urinary constituent finally moves to the site 4. It comprises of the distal tubule and the collecting duct, as we discussed earlier. Just focus in this diagram, the late distal tubule and the collecting duct makes the site 4. This site 4 is composed of the two types of the cells, the principal cells and the intercalated cells. It is clearly mentioned in this diagram how the sodium chloride and the potassium movement is taking place here, and the antidiuretic hormone is controlling the water movement. Then let us go through the major segments of the nephron and their functions. Before to start this, I have to explain the main concept behind the regulation of urea. The collecting duct cells or the thin ascending loop of Henle's both are the only segment that are permeable to urea, and the antidiuretic hormone promotes insertion of urea transporter into the luminal membrane of collecting duct. cells, so that the more urea is accumulated in the medullary interstitium, which reinforcing the medullary hypertonicity during the water deprivation. And along with this water deprivation, let us go through the first segment. This first segment is the proximal convoluted tubule. The function of this is in the reabsorption of 65% of filtered sodium, potassium, calcium and the magnesium. With this, 85% of NHCO3 and nearly 100% of the glucose and amino acid isoosmotic reabsorption of water is taking place. And the permeability of water at this site is very high, and the transporter and the drug target at its apical membrane is carbonic anhydrase. And the major class of the drug as a diuretic agent which we are using for this site is the carbonic anhydrase inhibitors. The next is the thick ascending limb of the pelvis. The main function of this site is the active reabsorption of 15 to 25% of filtered sodium, potassium and chloride. Secondarily, reabsorption of calcium and magnesium also takes place at the thick ascending limb of the pelvis. At this site, the water permeability is very low, and the primary transporter is present at this site is the sodium, potassium, 2-chloride symporter is there in this stoichiometric ratio. And at this site, the loop diuretics is the major class of the drug which acts on this site as a diuretic agent. Then the third one is the distal convoluted tubule. This functions as the reabsorption of 4 to 8% of filtered sodium and chloride. In addition to this, the calcium reabsorption under parathyroid hormone control is also takes place. The distal convoluted tubule is showing the very low water permeability and having the primary transporter, which is a major drug target, is the sodium chloride. And the major class of the diuretic which targets this site is the thiazides and the thiazide-like diuretics. Then the fourth one is cortical collecting tubule. The main function of this is the sodium reabsorption up to 2 to 5% coupled to potassium and hydrogen secretion. This site is showing the variability in the water permeability, and this site is having the primary transporter is the sodium channel and the hydrogen transporters. The major class of the diuretic works at this site is the potassium sparing diuretics, because a loss of the potassium at this site is the major fact. So a loss of potassium is taking place more at this site. That's why we are using the potassium sparing diuretics here to control the loss of the potassium by the process of diuresis. Then, in continuation to this, net movement of the potassium. The movement of the potassium taking place, it is majorly reabsorbed in proximal tubule and then thick ascending limb of loop of Henle's. It secreted in the distal tubule and the collecting duct. The net potassium loss depends on the fact that sodium load delivered to the distal tubule and the collecting duct, presence or absence of the aldosterone, availability of the hydrogen, and the intracellular potassium stores. Then let us discuss about the antidiuretic hormone. The characteristic features of the cell linings of the collecting duct cell is their responsiveness to antidiuretic hormone. The cell linings of collecting duct is very sensitive to antidiuretic hormone. If the antidiuretic hormone is absent, then the hypotonic fluid enters into the collecting duct and passes as such. That means the dilute urine is passed. But if the level of antidiuretic hormone is high, then the collecting duct cells are fully permeable to water, and so that the tubular fluid get equilibrated with hyperosmotic medulla, so that the concentrated urine is passed. So, already we discussed in the previous slide about the movement of the sodium at the different sites. Now, let us discuss about its movement in the percentage at the different sites. The diuretics causes net loss of the sodium with that of the water in the urine. The process is called as the nitriuretics. And the reabsorption of water at the different site of the nephron takes place in the following manner. At this site, at the proximal tubule site, the 65 to 70% of the sodium reabsorption is taking place. At this site, at the thick ascending loop of the Henle's, 20 to 25% of the sodium reabsorption take place. At this side, the distal tubule side, 8 to 9% of the sodium reabsorption takes place. And finally, at this side, at the collecting duct side, only the 2 to 3% of the sodium reabsorption takes place. So, that's all for the day. We will continue the same chapter in